Okay, let's just get started. If anybody cannot hear me, then let me know, okay? Maybe use the chat box. And as we go, please use the chat box to let me know of any questions that come up, okay? Okay, so I'm going to go through some of the new information that's come out over the past couple months. It's pretty exciting time in our field as we look for drugs that can slow the progression of Alzheimer's disease. And we've kind of come out of this time that's been very difficult where Medicare did not cover a class of drugs, and now they are covering them because the FDA gave them full approval, not just an accelerated approval. I can not hear you, but see you're speaking. I hear you now. Good. Okay, I have a lot of disclosures because I do a lot of work with these drug companies, and they're all trying to get a shot on goal to try to change the slope of this disease, as well as other trials that we do and a host of other neurologic diseases. Okay, so the outline is this FDA accelerated approval of a drug called aducanumab that was controversial, and since then it's been validated with two other drugs called lecanemab and donanemab. Coverage remains fraught, and go over how we enroll, how we monitor for side effects with these drugs, and then we'll just open it up to any questions that you guys have. So I wanted to start with this very classic case of a 51-year-old person who presented with what we call chief complaint of, I lost myself. She was a housewife, she was known to be diligent and tidy, and she had problems remembering things. And she had progression into making mistakes with cooking, became careless with spending, and worsening anxiety over many months, started pacing around the house without purpose. On examination, the doctor who saw her said she had a helpless expression. He showed her some objects, a key, a pencil, and a book. She named them correctly. But as soon as he put them away, what did I show you? She had no memory of seeing them. He said, I don't know. I don't know. And it was November 29th when he saw her. What month is it now? The 11th. What is the name of that month? The last one, if not the last one. So her brain came to autopsy, and the person who followed her until she was deceased and then took her brain and put it under a microscope under this special stain was Dr. Alzheimer. And that's why we call this Alzheimer's disease, because he correlated the phenotype, the way that she presented with these abnormal proteins that he saw in her brain. And that's pretty much what we see now. He drew these extensive drawings of these plaques and tangles, and that's exactly what the brain looks like now, because until now, without treatment, the disease has not changed at all. Into as long as humans have had brains, they've had Alzheimer's disease. And since the 1980s, we've known that this is due to this protein that gets cut and forms tiny little clumps of proteins that we call oligomers and further aggregate into these plaques. And along the way, they mess up nerve cells. And the way that they mess them up is that the nerve cells start developing these tangles that are downstream of the amyloid. And this looks really complicated, but it's really not, because it's really, whoops, I just went the wrong way. Here we go. Because it's this protein called amyloid first, then tau, and then neurologic problems, neurodegeneration, neuronal death. So we can now measure this disease in life. So meaning that we can take a scan and look at these proteins. And so here we see a positive scan on the left, where people have been injected with a tracer. The tracer goes into the body and it sticks in where the amyloid lives in the brain. And this person is negative, does not have that protein. And And this has allowed us to see the disease. And if you can see the disease, that's when you can see the goal and get a ball into the goal as a therapy. So this is a very important advancement in clinical trials. And we can also see tau, the tangle. So this is a person with mild disease, moderate and severe, and you can see that it kind of gets worse, worse, and worse with a little bit of tau, more tau, and then the most tau. Again, it's really complicated, but it really boils down to amyloid, tau, neurodegeneration. From normal, amyloid builds up, people enter myocardial impairment. As tau builds up, and then clinical function is sort of the last thing that goes. Amyloid, tau, neurodegeneration, ATN. So for the last 15 years ago, the field has been working on clinical trials that are looking at these antibodies. And antibodies look like these upside down umbrellas, a Y-shaped molecule. And the top of the Y sticks to something, and the bottom basically binds to a white blood cell that eats whatever this is attached to. And the target of these antibodies, you can create antibodies and you can direct them against this amyloid stuff because it's on the outside of the nerve cell, and these big molecules get into the brain and they float around and they stick to the plaques and they stick to these clumps and they get rid of them. And that's been the hope for many years. And we finally saw light. So what happens here is that the antibodies they bind to something, and this could be anything that the antibody is designed to bind to. It could be a COVID particle, it could be an amyloid particle, and then it invaginates it into a white blood cell. And in that vesicle, it will kill whatever is in there. And that results in this case, decreased amyloid and protection of brain tissue distally. And as you see, disease-modifying biologics, monoclonal antibodies really form probably the bulk of the shots on goal here. Not all against amyloid, that's in red, the red dots, and many small molecules as well, but many, many, many of these monoclonal antibodies that are trying to mess with the disease. Things were very dismal for many, many, many years until a trial was being done in a drug called aducanumab, resulted in a positive trial. This is really complicated because the trial was terminated early because of a false statistical signal that hinted at futility. But the futility was being driven by a negative trial, and there may have been reasons for that. And the positive trial was positive. And the positive trial also eliminated amyloid robustly, and the negative trial did not. Negative trials, and as we'll see later, there's now more reason to think that this correlation between not as much amyloid lowering in a negative trial and more amyloid lowering, perhaps past a certain threshold, and a positive trial where the outcomes split, is important. So more amyloid removal yields slower progression. Not enough amyloid removal, negative trial. Not enough amyloid removal equals no slowing. And this drug was fraught with danger because about a third of the people had brain swelling. And what happens there is that sticky protein, the clumps, get into these vessels and they make them fragile. When we get rid of the amyloid, then swelling can happen, brain edema can happen, and that's what this looks like. This is severe brain swelling in a patient who was on really one of the original monoclonal antibodies called bapineuzumab. I mean, this was over 10 years ago, so it really shows you how long we've been working on these things. For aducanumab, the drug we're talking about, there is also stratification with a gene called ApoE4. ApoE4 increases your likelihood of getting the disease, but it also increases your vascular amyloid. So more vascular amyloid, more prone to leaking. And brain edema occurred up to 2/3 of people who had 2 copies of that ApoE4 gene versus about 20% in people who didn't. Interestingly, placebo always causes brain swelling, which means that it's just part of the natural history. Brain swelling happens in people who have this disease. So aducanumab in sum was given accelerated approval by the FDA. The FDA puts this category of approval. It's an approval category based on a biomarker. Now that's easy to see when a tumor shrinks and the oncologists are like, yeah, this probably works because it's a validated biomarker, tumor shrinkage. But it's harder to see with a non-validated biomarker like removal of protein. The drug does what it says, but is that enough to work? Well, the FDA said it's reasonably likely to work. And as we'll see, they were completely validated, but at the time that was a really controversial opinion. And unfortunately, a lot of people, mostly in academics, but also on the insurance people, basically said this is bad. The FDA is wrong, and they undermined the FDA. And they had some legitimate cover. I mean, these people weren't completely insane because there was a pretty high risk of this ARIA, of the brain swelling, up to 2/3. And if they had good motives to keep people safe, then that's good. But a lot of them were sort of taking autonomy away from patients. And Medicare really did that because Medicare broke with precedent. And for the first time ever, they did not cover the drug. The FDA gave it approval, accelerated approval. Medicare said, we're not covering it. So the drug basically died. And, with respect to our elected leaders and the people that they appoint to lead these agencies who have immense power, Medicare was completely wrong and absolutely horrible on this. And you can really see that during a hearing, a congressional hearing, where some of the senators were like, look, we have an accelerated approval here. We have an approval of a drug for Alzheimer's disease. My constituents, some of them would like this drug. So what would you like to say? And the commissioner of Medicare, this woman, who in a couple of years is going to be working for an insurance company, they asked her, what other FDA-approved drug has been denied coverage? And to which she said, we are not denying coverage. But she is denying coverage. She's denying coverage to patients outside of clinical trial, which is most patients in most states who can't make themselves available to clinical trials. And I'm a trialist. I like clinical trials, but this was abhorrent. The absolute failure of leadership, failure of just answering a simple question. I mean, stick to your guns and say, listen, I am going to discriminate against Alzheimer's disease, and we're not paying for it. Full stop, right? I mean, at least be honest with the American public. So the dishonesty, misleading statements, not answering questions, all of that total nonsense, thankfully, was settled because science settles it. Data settles things. These disagreements, ultimately, the data solves everything. But for a time, it was like a big fight. So first night at Fight Club, you have to fight. I think that's like rule number 3 or something. The FDA said this is reasonably likely to work. They gave it accelerated approval, and the emphasis per the FDA is on approval, not on accelerated. The accelerated part just means that the drug company is required to conduct a validating trial. And Medicare said amyloid is a cause of the disease or versus a marker is controversial, which is false. Again, misleading statements. And no Alzheimer's drug has succeeded in modifying disease progression. But that's false because I just showed you the data for aducanumab that one trial was positive, one trial negative. So that's just a false statement. They just ignored the positive trial and concentrated on the negative trial. And humans do that. But unfortunately, people suffered as a result of this. And just as an aside, for non-Alzheimer's disease drugs in 2019, Medicare spent $1.2 billion, and that's our money, on accelerated approval medications. So again, when I say broke precedent, they broke precedent. This is completely unheard of in any drug until it came to Alzheimer's disease. And neurologists are going to deal with this more and more because accelerated approval is now a thing. It's a thing for aducanumab. It was a thing for a couple other Alzheimer, for at least one other Alzheimer drug. And a recent approval of an ALS drug in a super rare condition called tofersen, it's approved for a subtype of genetic ALS, is an accelerated approval, okay? Accelerated approval for ALS. And there is no way that any insurance company or Medicare would dare say no to this. They would only pick on Alzheimer's disease. Why? Because prejudice and stigma of the disease. ALS and cancer, you fight, you fight, you fight. And basically, the Medicare is playing into the stigma of Alzheimer's disease. Alzheimer's, old timers, can't remember shit. Those are euphemisms for the disease for people who aren't brave enough to engage with the actual proper words of this disease. Again, ALS, you fight, it has a name, it's bad. Alzheimer's, no one's ever survived it, but basically, you know, sweep under the rug. You're old, go away. And furthermore, they broke with precedent. Medicare broke with precedent. And breaking with precedent is a very dangerous thing. Precedents exist for a reason, because power structures and hierarchies and responsibilities and roles are established through precedent. So the second break with precedent was the morning after pill. So no matter what you think about abortion and morning after pill, this was another time when the FDA had an accelerated approval for the morning after pill, for this abortion pill. A judge said that this was improper, a judge in Texas. And now that judge, he's not like biotech, right? He's in the law side, and he's probably not a terrific judge, FYI, but he's also not aware that he didn't really break precedent. The first time this happened was with Medicare. The second time it happened was here, with the FDA getting overturned. The FDA said this morning after pill is safe and reasonably likely to be effective and good enough. Let's approve it under this accelerated approval pathway. This judge said, not so fast, almost 20 years, more than 20 years later. So we'll see more of this, unfortunately. And with the FDA taking a hit and being diminished as a regulator, that's not a good thing, because their entire job is to do one thing, and that's to approve or disapprove and monitor drug safety, as well as a bunch of other things like food, obviously Food and Drug Administration. So Medicare was not paying for this. It was a public health catastrophe. 2,000 people a day became ineligible for the treatment. And it was really financial fraud, because these people paid into Medicare all their lives and they didn't get their money back. They didn't get coverage. So what's that? I call that fraud. It's bad for trials. It's bad for investments. What shots were we not going to take? And compare it with the tofersen, with NFL as a surrogate. Biotech is very enthusiastic about that, because they know in a phase 1 trial to phase 2 trial, if they can lower a surrogate biomarker, then they have a good shot on goal. They're probably going to succeed. But because of all this confusion, shots are not going to be taken. No one's going to finance these trials. So basically, you know, this is a cartoon for what Medicare would tell people. Okay, so since then, Medicare has been sort of falsified. They were wrong. And why? Because again, science settles these debates. Another drug called donanemab is in clinical trial, and that hit a phase 2 trial. And what you see is very similar. It removes amyloid very robustly, and it diminishes progression a little bit. And that was verified then in a phase 3 trial, same drug, just bigger population, and it showed basically exactly the same thing, decreased progression. And then lecanemab, which is currently on the market with full approval, which is a monoclonal antibody against these little clumps of the guys, not the big plaques, did the same thing. This is a phase 2 trial, markedly lowered amyloid and split with progression. And that was again seen again and validated in a phase 3 trial. And you see the same pattern. Robust removal of amyloid yields decreases in progression. And the secondary metrics are positive on everything, including these quality of life measurements, functional measurements, and thinking cognitive measurements. And so the modeling of this is even worse for Medicare because the delay that we see in terms of time over a year of placebo, the people on the drug delay their progression by 5.3 months. And if you extrapolate that, then what you can see is that people will spend more time in a very mild state. So 2.5 years delay from progressing from mild cognitive impairment into mild Alzheimer's disease. Now, Medicare, for what it's worth, also looked at this data and said, it doesn't matter, it's not approved until July, until full approval. So, I mean, more of the same. You know, go Alzheimer's, go screw yourself. Anyway, so emerging picture across amyloid drugs, I'd be very remiss to say that we are completely standing on shoulders because so many people got into these trials, and even the ones who got into failed trials, negative trials that barely affected progression. These 2 trials did affect progression, but not enough, right? 8% and 6%. The people on treatment did better, but only by 8 and 6% in these trials. And why? Well, it's correlated with less removal of amyloid. They didn't remove amyloid enough. This is a measurement of amyloid that is remaining in the brain. And you see all the negative trials, including the aducanumab negative trial, they're not enough in the 30s and even 50s here. If you want to change the disease in a good way into the 20s, you got to remove the amyloid robustly. And this follows there's a busy slide, I'm sorry, but it really follows a bunch of these other drugs like bapineuzumab. That was that brain swelling that we just saw. That also removed amyloid, but not by enough. If you track them all out, what do you see? You see removal of amyloid here and getting better cognitively and functionally here. Busy slide, I'm sorry. What we see in terms of effects is similar across trials, just looking at the positive trial, unfair. But if you look at the positive trial and compare it with these guys, you basically see the same thing. So these drugs are not without side effects. They have side effects, all right? So side effects. Again, it depends on this ApoE4 allele, this gene that we all carry. And some of us have ApoE1, ApoE4. Some of us have 2 of it because we inherit 1 gene from each parent. We pass on 1 gene to each kid. And so we all have 2 copies of every gene. And if you're 4/4, you have extremely high risk of Alzheimer's disease, but you also have increased risk of the bad symptoms. And that also increases from lecanemab, which is pretty low, although 1/3 of people who are ApoE4. The new drug donanemab, which will be out in about 6 months, it goes up a little bit. And then aducanumab, it goes up a lot, it basically doubles. So knowing that, we have to look at people and keep people really safe to try to avoid that brain swelling. Part of that is actually just checking ApoE4. That's part of it. We know people will be low risk or high risk. Part of that is an MRI. So MRI is done, it can see little bits of brain hemorrhage that have leaked into the brain from having amyloid in the brain. This person has multiple leaks indicating huge amount of vascular amyloid, cannot mess with amyloid, should not get the drug. This is one area and a little bit of another area. That person could get the drug. Lecanemab, that drug which is approved, is generally well tolerated. So people did well in the trial, but in the open label, there were some deaths. And one of the people who died suffered a stroke and was given a medication completely appropriately for that stroke called TPA, which dissolves blood clots. And unfortunately, that person died of massive hemorrhage. And here's the autopsy, the brain. You can see these multiple areas. And you can see the microscopic amyloid in the blood vessel that basically became very friable and probably just leaked out a bunch of blood. So with these drugs comes monitoring. It has to be monitoring with an MRI, and it's done very front-loaded prior to the first, fifth, seventh, basically every couple of months to start, and then every 6 months after that. Because the ARIA, the brain swelling, occurs early. There are rules for suspending dose and taking a look for stabilization and resolution for ARIA swelling, because what we don't want to do is dose through it. And here's a person who was in a trial, and the person had minimal ARIA, which I think you can appreciate here as just being like a little bit of cloudiness. And here versus here, you can kind of see there's a little bit more cloudiness. And if you can see that, then you're better than the radiologist, because the local radiologist missed it and the central radiologist missed it, and the person got dosed through this ARIA and created this blooming ARIA. So if you couldn't see it here prospectively, you can certainly see it in retrospect. And that's the problem with radiology, FYI, because radiologists, with their work, it can be seen by everybody forever. Right? You check the chest X-ray here, it looks negative. 3 years later, there's a tumor. What was that shadow? Right? You can see it back then. So they kind of have the retrospective scope, and this was not called, and it bloomed. And the patient, meanwhile, is completely asymptomatic, thankfully, and have absolutely no problem. On MRI, how do you tell the difference between plaque and previous TIAs or mild stroke? So MRI would tell the difference between MRI wouldn't see a TIA. A stroke looks different than this, and a PET scan wouldn't evaluate TIAs or strokes. A PET scan is only for the protein or not. The PET scan can look at the plaque, the protein. An MRI scan looks for strokes and brain swelling. This is another case of brain swelling, and you can see it's very subtle and resolved in basically a month. And it also goes to show how long we've been working on this. 2009, very long ago. When the brain leaks out a little bit of blood, there are also suspension rules, and we want to keep this safe so that, unfortunately, this drug is just not appropriate for people who have 5 or more of these little microhemorrhages, or a macrohemorrhage, or any other lesion that increases risk. So on July 6th of this year, the FDA gave it full approval. So neurologists have got to now figure this out. And in the past, over the past decades, there's been a lot of nihilism about Alzheimer's disease. What does it matter? Who cares? If I call it memory loss, I call it Alzheimer's disease. Why even trouble people with the disease name? Well, now there's a drug out there. And so I see many people on Aricept, which is a drug for Alzheimer's disease. Why are you taking Aricept? Oh, I take that for my memory, right? Well, it's appropriate for Alzheimer's disease. They thought you had Alzheimer's disease. That's why you're taking it. They didn't tell you that, but that's why you're taking it. And so neurologists are going to have to get comfortable with these genetic conversations with being wrong with people who look like they have Alzheimer's disease, Alzheimer's phenotype, but negative biomarkers. They don't have the amyloid, and that can happen. And sometimes the test looks like what you think, sometimes not. And getting comfortable with margins of error is going to be tough for a lot of neurologists. We have to keep in mind risk tolerance. So with oncology and stroke, risk. What do you want? Chemotherapy has risk. Cancer has risk. Finding a way of balancing chemotherapy with the cancer risk, that's the art of medicine, and figuring out what this person wants, what their risk tolerance is, how much they want to do. We're going to have to get like that too. And a lot of neurologists are risk intolerant. That's fine for them, but maybe they're dealing with a person who is highly risk tolerant. For instance, I'm risk tolerant to some degree. I jaywalk. I'm risk tolerant to the point of mountain biking, but I'm not risk tolerant to the point of surfing a 100-foot wave. I'm not going to go to Utah and go to one of those mountain bike parks where they're jumping 30 feet in the air. So we all have limits, right? Risk tolerance, that's an individual decision. And then with ARIA, we have to keep that mild and asymptomatic. Keeping it mild means monitoring, catching it early, holding doses. And then, sad to say, the coverage issue is yet another issue. Highmark Blue Cross and Independence Blue Cross have said they are not going to cover it. And here's the quote. This is her. I mean, I just can't believe, I actually reached out to her because I find this so appalling. And I just wanted to discuss that I think that she's becoming a fall guy for the insurance company. Now, obviously, she has a conflict of interest. Her employer is an insurance company, and if they don't pay for lecanemab, then they get to keep the money, and that's her money. So reevaluation, not clear of what, made it clear to us that existing evidence does not allow for conclusions to be drawn about the safety and effectiveness of Leqembi. That's the name for lecanemab. I mean, that's a completely false statement. It's not clear at all that we can't make a comment. In fact, the data has been so complete that the FDA voted unanimously for full approval, and it was given full approval. I'm hard pressed to think of any situation where an FDA approved drug is just not covered by an insurance company, inappropriate use. But again, Independence Blue Cross and this woman who's a geriatric doctor and should know better, right? And actually was on the radio for how Independence Blue Cross supports seniors. This is a disease of aging. She herself is now using this stigma to make a non-coverage decision. So further trials, and we're almost done. I'll get to the questions. Lecanemab reduces progression by 27%. So, this is completely false. It reduces progression by 27. And we're going to work on the other 73% and get better symptomatics. So further trials are underway. Lecanemab is in the middle now. It has a gold star. It's within approved. And that's it. Okay, so let me get to the questions. And once a patient has been diagnosed, how often should they receive MRIs? Well, unless they're on lecanemab, then the answer is basically never, because it won't change management. But on lecanemab, then they should get the MRIs before the 5th, the 7th, and et cetera. But otherwise, don't bother. Does Aricept have value? Yes, Aricept increases a neurotransmitter that increases memory. Trials were done in it, and hundreds of people on both sides, the people on Aricept did better. They did better in testing. They did better functionally. People who didn't get Aricept didn't do as well. It's symptomatic only, however, so if there's any side effect with Aricept, then don't bother with it. This is a specific case, someone in their 90s with moderate memory loss, have a neurologic evaluation. Yeah, sure. I mean, it sounds like there's a source of problems. Whether it wouldn't be probably not appropriate for lecanemab, but I wouldn't close the door entirely. Lecanemab was studied up until the age of 90. And there are plenty of people in their 90s who, it's just a number. There are plenty of people in their 90s who look like they are in their 60s. And actually, a lot of people in their 60s look like their 90s. So I wouldn't close the door necessarily based on a number. But that said, at the age of 90, I think that maybe there could be other things you could be doing. But yeah, get a neurology opinion. If there's a concern, talk to your primary care doctor. Independence Blue Cross has not been an appropriate insurance company for decades. There are better options. There are definitely better options for this. I think that they're going to have to revise themselves, and it's really sad to see a doctor sort of dragged down into the mud and forced to be the target, be the scapegoat, be the fall guy for this. Okay, they have a Down syndrome. So Down syndrome dementia is Alzheimer's disease. That was one of the first genotypes that was linked with this disease, because people who have Down syndromes in their 40s and 50s inevitably develop amyloid, that protein. And why? Because the gene that codes for that protein lives on chromosome 31. And instead of 2 copies of the gene, people with trisomy 21 have 3 copies of it. And with 3 copies of it, they have 150% of the normal load. 150% of the load equals Alzheimer's disease, inevitably in their 50s, and usually in their 40s. And they build up the protein a couple decades before. How long does a person have to be on lecanemab? So it's unknown. Most people on lecanemab convert to negative on treatment, on PET scan. About 70 to 80% of people convert from positive PET scan to negative PET scan. That said, we don't fully know, and we don't know how to get off of lecanemab. Certainly, when the disease progresses past a point where it's reasonable, that's probably when we could stop it for sure. If there's any side effect or problem getting it, then you would stop it. But we don't know for certain. I think that the answer would just be individual for everybody, okay, until we really know more. There is a second drug, that donanemab drug that I mentioned. That's kind of a special story, because they robustly reduce amyloid, but also because the drug makes people get anti-drug antibodies that could be a problem. That company, Lilly, is very firm that the drug needs to be discontinued when people convert to negative on a PET scan. Medicare does not currently cover PET scans, right? Remember that discrimination. Medicare covers PET scans for other things, but not for Alzheimer's disease. No to that. They're going to change their tune when donanemab comes on the market, because it'll be cheaper to get a negative PET scan and then de-escalate donanemab. That has a firm off-ramp. Lecanemab does not have a firm off-ramp. What proactive steps can children of Alzheimer's patients take to, if they are in the early stages themselves? Well, see a doctor. That's a pretty simple one. See a doctor with any memory concerns. For prevention itself, the only thing that people would say is sleep well and exercise. That's it. There's a person who is a moderate to severe stage of the disease and has a pacemaker, cannot get MRIs. So MRI is necessary for lecanemab. No, cannot tolerate an MRI, cannot get an MRI for any reason, cannot get lecanemab. And then the lecanemab was useful in the earliest stages of disease. That's where it was studied. And later in the disease, It is not useful. Okay. There's just all risk and no real benefit there. Because the disease is a continuum, it's very difficult to close the door at a single step along the disease progression. That said, later, not good. Up here, that's the best fit. People who are interested in starting treatment one place, going to another place, because the drug is every other week, that would be totally fine. That would be no problem. Lecanemab treatment will become widely available. Right now, actually, like this building where I work, we were the first people to dose the drug commercially, like in the state, I think. I know, in the state. But there are going to be so many other people now that has full approval, they're going to start dosing it. So we'll get there. We'll get there. And actually, it'd be fine to do it now because I have full confidence that places where people go to retire will be some of the earliest adopters. Medicare and Highmark Blue Cross secondary insurance. I think that they said that if Medicare is the primary coverage, because Medicare covers it, then these blood-sucking parasite insurance companies will be fine with covering it as long as Medicare is paying the brunt of it. Okay. I think that's what they said, but you'd have to figure that out with our office or whatever doctor's office. Allergic to donanemab? Probably not. The drugs are different enough so that an allergy wouldn't necessarily be cross-related. Now, allergy is sort of a word that's fraught with danger because people are allergic to drugs, but really that means they had a side effect of the drug. If you had donanemab and had a side effect from it, it probably wasn't an allergic reaction as defined by 90% of people. Allergic reactions get hives, itchy throat, swelling in the throat, and we want to prevent that from becoming anaphylaxis. Get the EpiPen out. So it's unlikely that the person was truly allergic to donanemab. Would they then have a cross reaction immunologically with lecanemab? Probably not. Would there be a side effect with lecanemab? Yes, probably, because there probably have some other kind of immune reaction or some other reaction to just getting the infusion. And that could be the same. Should a person with memory loss have a PET scan? Well, Medicare does not cover PET scans. So again, Medicare just said, we're not covering this. How about never? Call me never. So if you're interested in lecanemab, the way to confirm the biomarker, the way to confirm the protein is to perform a spinal tap, a lumbar puncture. It sounds like a lot, but it's actually not that much. And we take a little needle. I do it in the office. I literally do it right over here. Take a little needle, put it in the low back, drain off the fluid the brain sits in. And you're basically getting like a poor man's biopsy of the brain. And there are ways to predict whether that brain fluid correlates with brain proteins or not. And so we've had people, it seems like 80, but no biomarker. And so you really need to get target acquisition before you fire with lecanemab. So it makes sense, right? You don't see the target, hold your fire. You see the target and then go ahead and fire. In this case, dose with lecanemab. But again, amyloid PET scans are not covered. And here's another, so here, just FYI, donepezil, that's Aricept, seems to have a positive effect in the first 6 months of taking it. So does Aricept work? Well, here's your answer to a little bit, one person's opinion, but yeah, it works. And I see this pretty commonly. It seems to have a bit of a positive effect. And It can also help what we call the neuropsychiatric problems of the disease. So the brain creates a mind, and people who are my patients have heard me say this, the mind creates, um, fills in missing memory and problems with not just frustration, but also real anxiety and depression and apathy and sleep problems and irritability and being stubborn. And those are very treatable. And one of the treatments is actually better memory. Better memory, those neuropsychiatric problems sort of get better. Will a tau scan be required for donanemab? That is unknown. I will tell you that Lilly, the drug maker who makes donanemab, wants it to not be the case because tau scans would be one more hurdle in the way. And when you have a hurdle, it's like a dam and the water will just go to lecanemab. So Lilly does not want that. I don't think it's going to happen. I don't think that Medicare is going to, or the FDA is going to say that tau scans will be required with donanemab. So Lilly did something very clever and a little bit unseemly, I will say. And apologies to anybody if Lilly is listening to this. But they studied the disease in minimal tau, like mild to moderate tau, but they also included more moderate to severe tau in the phase 3 trial. And then they're making some claims saying that the minimal tau, they did better than lecanemab, more effective. Well, that's not really fair. It's kind of fair, but if you just look at all of them, then it's about the same as lecanemab. And I don't think there are any major differences. So they did that phase 3 trial because they didn't want the tau scan to be required. Okay, so I don't think it's going to be required. How does memantine work on Alzheimer's disease? Memantine is a different drug. It changes a neurotransmitter that's a coincidence detector in the brain. So nerve cells, this neurotransmitter, or it's a long story. I don't want to get into the weeds here. Memantine helps nerve cells pay attention to what they should be paying attention to and learn better. That's what memantine does. There are some claims that by decreasing calcium influx into cells, it could help cells be a mild neuroprotective. That's a bit of a claim. It's only been validated in sort of later stage disease. That's when it works. Okay, so it doesn't work early on. It doesn't work in myocardial impairment. Doesn't work in even early Alzheimer's disease. When the thinking loss becomes apparent, memantine can work. But when thinking problems are very minimal, memantine has nothing to work on and it cannot work. So the worse it gets, then memantine is appropriate. And it's a very weak medication. It doesn't work very well, but it also causes almost no side effects and it's on generic. So it's completely non-problematic. Okay. Yeah, so just that's it. Thank you very much. It's been awesome. You guys have been very engaged. Thank you so much for that. Give another minute or two while I babble on for any other questions you guys have or any follow-up questions. Little pitch for Abington Neurologic. We exist right across the street from the hospital. Vintage is across the street as well. That's like the local bar. Across from the police station. All my partners are really good. And we are excited about this as the first disease-modifying agent in Alzheimer's disease. Oh, some more questions. Crystal ball, near future, hold to help the condition of dementia. Well, crystal ball is the only game in town right now is lecanemab. Coming out of the gate, the next generation of drugs are going to be other drugs that decrease amyloid better and are better tolerated to get rid of that brain ARIA to make that less of a concern. That's what's going to help. I think everything else is sort of in earlier stage, but I'm really looking forward to polytherapy. So remember, HIV, that was not cured with AZT. The first in class is not the best in class. First chemotherapy was nitrogen mustard gas, not the best chemotherapy. over time, it became better tolerated, polytherapy, and look where we are now. So I think eventually we'll get there, but it's going to be a lot of work. How is someone who's able to get an MRI receive the LP? Well, you can get the LP, but it's not going to help because you can't monitor the progression or the side effects of lecanemab. So lecanemab is off the table. Will the recording be made available? I believe that that's a yes. It's recorded. Yeah. Any other questions? Just give me a call. Okay. Better medications in Europe. That's a weird one. Actually, no. In fact, Europe is probably going to approve lecanemab, but I don't know if they're going to be able to pay for it. Certainly, England is not going to be able to do this. Their National Health Service is stretched way too thin, and they're not going to be able to implement this at all. They're just not there. There are no better medications in Europe. In fact, Europe is, I don't want to throw stones. Europe can be very beautiful, but in terms of medicine, they're not there yet. So we're looking at like rest of world. You're probably going to see Japan do better because they're facing an aging population. They're very interested. Eisai is actually a Japanese company. So we're going to see like rest of the world, probably Asia lead. And then we'll see what happens with Europe. European Drug Agency will probably approve lecanemab, and what they come up with, I don't know, but there's certainly nothing else. Right now, lecanemab is available here, and if you're in Europe, it's not available. Do amyloids get back to after do they rebound? The answer is yes, probably. They do build up again. I will say in natural history of Alzheimer's disease, it's 1 to 2 decades before the onset of symptoms that amyloid occurs. So it kind of makes sense that it would take some time for them to get back to where they were, a decade or 2 decades. But once they start clumping and aggregate, then it might be a different story. They might come back quicker. They might form more toxic species and get bad faster. And that may be a case of continuing dosing. Again, Lilly is very convinced that they can stop donanemab. I don't know about that. I think that that's maybe wishful thinking. We've started patients on lecanemab. Absolutely. I now consider lecanemab to basically be standard of care unless there's a reason why it shouldn't be given. And that could be a financial problem. That could be a getting here problem. That there are a lot of problems with lecanemab. But yes, we have started people on lecanemab, and I think, again, it's going to become more of a standard of care. Okay, meaning like after a heart attack, everybody takes aspirin, right? And unless there's a problem with an aspirin allergy or a history of easy bruising and bleeding. So yeah, that's kind of where I think the field is going. And again, there can be reasons why we continue to do trials for individual patients, but right now, lecanemab is sort of the only game in town. Okay. Good. We're at the kind of top of the hour. So any other questions, give me a call and I will return your call. Thanks, guys. Bye.